everybody. Welcome to this, our 5th International League Against Epilepsy e-forum, tackling a specific topic with discussion. And it gives a great pleasure as the president of the International League Against Epilepsy, I'm Helen Cross, to introduce this e-forum on outcomes beyond seizures. We have a set of fantastic panelists and speakers for you today. Not least Sallie Baxendale from the UK, Scott Demarest from the USA, and Joe Wilmshurst from South Africa. When we're treating the epilepsies, of course, we strive to control seizures where possible, if not trying to achieve optimal control. Seizures do remain an ongoing target, but in many circumstances, there are other things that we need to consider, particularly more in the more complex epilepsies. But think of other comorbidities, outcomes that may be important to patients and their families. So what we aim to do in this session is explore some of those outcomes and how we may consider those in different forms of epilepsy. We'll go to the next slide. What we will have is a series of talks over the next hour. Yes, if you think of questions and answers, please type those into the question and answer box at the bottom of your screen, although we will not answer these until the discussion beyond the hour. And at the end of this e-forum, we will ask you to complete a short survey for feedback as to how things can be improved in the future. Before we start, I do want to thank our sponsors, not least Jazz and UCB, who are silver sponsors, and further sponsorship from Neuralis, and also highlight that we cannot answer specific questions on specific cases. This is just to look at general points as we move forward. So as we start, I'd like to introduce our first speaker, this being slide just showing their conflicts of interest, but introduce our first speaker, Joe Wilmshurst, who's Professor of Pediatric Neurology at the University of Cape Town and also head of the Pediatric Neurology Department at the Red Cross Children's Hospital in Cape Town. And she's going to introduce the concept, looking at very specific cases with regard to outcomes beyond seizures. Thank you, Joe.
Thank you very much, Helen. So it's my great pleasure to cover this topic on outcomes beyond seizures with a slightly African tilt to it. So the story I'm going to tell you, the case illustration, is a real case, and the family have 100% given permission for the story to be relayed. There is a video. I'd ask you not to copy the video, please. So the aim of this presentation is to understand the challenges parents face in the decision-making for early onset seizures, to assess the long-term implications of drug-resistant seizures, and to understand the burden of disease from comorbidities, even if the epilepsy is controlled, and to consider the complexities of transition of care. So this is the case, MDM. He was 2.5 years of age when he was referred into our government service. At this point, he had normal development, and the referring clinician was worried that he thought he might have new onset seizures. So this So when we see these patients, what we do is use in my center, we use the PET course, the Pediatric Epilepsy Training Course guidelines for the Describe that was devised by the BPNA. So when we think about the description of what happened, this is what the mother described, that the child was sitting, he turned his head to the right, he looked at his mum, and in fact, as he got older, he was able to say that he could feel something coming on, and his mum asked him what was wrong, and then his right hand fisted and his right arm postured. He remained aware through a lot of the event that I showed you, but in fact, some of the other ones, he would have propagation to bilateral synchrony and would certainly lose awareness. So in fact, these are epileptic events, and we would describe these as a focal seizure with a sensory and then motor component to it. Is it part of a syndrome? We don't know, but I'm going to show you now what his neuroimaging showed. So here, what we see is on his MRI, there's really quite obvious dysplastic lesion in the left temporal lobe that we felt was consistent with a low-grade tumor or a DNET. So he was he was then incremented on various anti-seizure medications, including carbamazepine, topiramate, and clobazam. These were optimized, but he remained drug resistant. And at this point, his development and behavior started to deteriorate and become an increasing concern. So what would you do next? What would be your next move? Would you add on more anti-seizure medicines? Would you challenge the family's adherence? Would you start the ketogenic diet? Would you refer him for an epilepsy surgery assessment, or would you put in a vagal nerve stimulator? Okay, so we've got 6% that are going to add on some more anti-seizure medications, another 6% that are going to challenge the family's adherence, 12% want a ketogenic diet, and I am very impressed. 73% are in agreement about an epilepsy surgery assessment, and 3% would go for a vagus nerve stimulator. Excellent. So the family were offered epilepsy surgery in this setting where there was a lesion that appeared operable, and so certainly given the choice in a drug-resistant child. And unfortunately, after extensive counselling, they declined epilepsy surgery. And not surprisingly, the seizures persisted. He had frequent focal events. His weight, as he aged, became an increasing issue, as well as neurocognitive and behavioural issues becoming a major challenge for the family. At one point, he assaulted his sister in an outburst of emotion, and he started showing very clear signs of autism spectrum disorder. School placement was just impossible. No one could keep him. His mum stopped work to care for him at home, and she's tiny. And during many of his events, as he would collapse, she would try to protect him, and he flattened her on quite a few occasions. So when I wanted to present this case, I phoned them and I said, just remind me what happened and why you declined the surgery. And what they said was the neurosurgeon gave them very clear advice. And in those days when, in my centre, when we were offering epilepsy surgery, we only had a few caregivers and the resource was very much a luxury. And so the neurosurgeon went and spoke to them on his own and gave them the really detailed descriptions. He told them it was a high risk procedure. It was absolutely life-threatening, and that under no circumstances could he ensure that the epilepsy could be controlled, and basically put the fear of God into them. And so, not surprisingly, they elected to revert back to their community support and put their, as I said, put their faith in prayers and just hoped for a miracle, which clearly didn't happen. So, roll on many years later. He's now 11 years of age, and this is 8 years after those conversations happened. And we'd been seeing them regularly in the clinic, and they turned around and they said, we've been hearing that you're doing this procedure on other children, and actually we'd like to revisit whether it's a possibility for our child. So what would you do in this situation? Would you agree to refer for an epilepsy surgery assessment? Would you counsel the family it's too late as the disease is now established? Would you assure them that epilepsy surgery will resolve all of his medical issues, or would you decline to refer them as they really should have agreed when he was 3 years of age? So proud of you all. So 92% agree that they should really be given the opportunity and to refer him, even at this stage, for an epilepsy surgery assessment. That 5% thought maybe it's too late. 3% would assure them that we could cure all, and that none of you would decline the option to refer. That is absolutely superb that so many of you would consider referring this child for the second chance. So indeed, he was referred. And in our setting, it took some time to actually just get him into the scanner, actually, to review the situation. He wasn't particularly cooperative, and to actually get the capacity. So the operation finally happened when he was 14 years of age. The family were delighted with the outcome. He basically had no seizures in the post-operative period, but his neurobehavioral issues persisted. So what would you do in this setting now with his anti-seizure medications? Would you continue them for life and say to the family, well, actually, you need to carry on? Would you stop them immediately in this post-op period? Or would you wait until 3 to 6 months and then stop them abruptly? Or would you sequentially wean them from 3 to 6 months? Okay, so small number, I think we're in the long haul and would continue for life. I'm very glad that none of you would stop it immediately in the post-op period. Some of you would just make the break at 3 to 6 months. And this is semantics, I'm afraid. It's a little bit confusing, but most of us are not that brave. And most of us would sequentially wean anywhere between 3 to 6 months after the procedure. So that was basically what we elected to do. And what subsequently happened with him is that he had this fantastic period. We managed to get him off all of his anti-seizure medications, weaning him gradually. We chose 6 months. It's not a fixed decision. And he was seizure-free for 2 years. And then he started getting these intermittent minor focal sensory events, sometimes with a little bit of motor involvement. But the family said, this is fine. These seizures are of minimal impact and we can cope. But the rest of the story is that by the time he was 18 years of age, he weighed 100 kilos. His mum, who, as I said, is tiny, remained at home as the main caregiver. And so as a way to describe him, he had a functional age of about a 2-year-old, but in a very, very busy, big body. He was hyper and moved around everywhere. So there was no placement that could cope with him. We had superb support from our psychiatry colleagues. And we were now in the position, and have been in the position, of trying to persuade our adult colleagues to take over care. And also most of my latter conversations with the family have revolved around aging parents and what are you going to do about this child in an adult body as you become too old to look after him. So by this point, he was on a number of neurobehavioral agents guided by our psychiatry colleagues. We put him on just a whiff of carbamazepine just to try and temper some of the seizure events, although they felt that was a minimal problem. And just of note here, he was on allergy medications because in addition to all his other problems, he had obstructive sleep problems at nighttime, probably compounded as well by his weight. But it really highlighted that these would then also exacerbate his behavioral problems. So really looking beyond the immediate neurology that we tend to do and looking at anything else that might help the family. So just really as take-home messages of this particular story, this particular child's history. It's never just the seizures or the epilepsy, that in this setting, the comorbid neurobehavioral and neurocognitive issues have been by far the greatest burden, in fact, for the family over the years. And even with the resolution of the epilepsy burden, although this undoubtedly improved his quality of life, they still have to deal with the child as a whole. Whether operating earlier would have actually reduced the level of these comorbidities, who knows? But I think many of you would agree with us that we think it probably would have made the burden less for the family. And then, is this a resource poor issue, resource poor setting issue, or is this a common reality? Well, unique, not so unique regional concepts is that the refusal for surgery related to cultural preferences, it's often layered by uncertainty and anxiety. And as illustrated by the initial neurosurgical counselling, it was very comprehensive and probably relatively correct in some of the points, but there needs to be a balance. And the family, when they chatted to me later, said that they really felt they were left with no choice, that they couldn't agree at that point to put the child through such a risk. So when we approach epilepsy surgery, it's really important to have a multidisciplinary team that talk together and that give a consistent message and that are experienced. And this in itself is probably one of the most challenging areas in low and middle income countries. Thank you. I will hand over to Helen now for the next session.
Thank you. Just to put over and just ask a question, Joe, before we move on. But I mean, I think, you know, you've illustrated that there was an issue at the beginning and decision making. You know, how much can we be sure that we're going to make an influence on those other comorbidities, and how do you counsel that at the start? I mean, that's not necessarily a resource poor setting issue, but thinking we can be more secure about seizures. What about cognition and behavior?
Yeah, I completely agree with you. And I think that's what people often forget. They're so focused on just controlling the seizures, they forget that there are networks involved and this incredibly precious growing and maturing brain, that you basically got this moving target happening and critical opportunities in which to make a difference. And that by leaving this child with these seizures going on for so long, I'm very sure that this child's problems were exacerbated by this. And the family, in fact, have very good insight into that. And they just say this was the decision they made, and this is what they had to live with now. But it's heartbreaking, actually.
That's a very pragmatic approach on the part of the family, but it is a shame. Exactly. Okay, perhaps we'll return to that later. But we're now to move to something slightly related but different, if I say that. Looking at the comorbidities and outcomes perhaps from developmental and epileptic encephalopathies. And for this, I'll introduce Scott Demarest, who's Associate Professor of Pediatrics and Neurology at the University of Colorado School of Medicine and Clinical Director of the Precision Medicine Institute at Children's Hospital, Colorado. Thank you, Scott.
Thanks so much, and thanks for the invitation, Helen. Appreciate it. We can move forward with the slides. So I'm going to talk about developmental and epileptic encephalopathies and how we could think about approaching the full range of neurologic manifestations for the DEEs. And I'll use a case example to highlight some of this. So when we think about DEE manifestations, this is a long list, the point of which isn't necessarily to read off bullet by bullet, but that we have obviously epilepsy, which I've placed purposely at the very bottom of the list, as well as developmental delay or intellectual disability. But there's also often GI problems, behavioral challenges, sleep issues, scoliosis, movement disorders, communication, hypotonia, a full range of neurologic manifestations that are potentially involved with a DEE. Not that every patient will have all of these manifestations. Next slide. And what this results in is that oftentimes seizures may actually not be the biggest challenge for a family, but there may be other aspects of their manifestations that are actually driving poor quality of life. Next slide. And so I'm going to use this particular case, a case of CW. This is actually an amalgamation of cases rather than a specific one. CW is just something that we can refer to. This is a 7-year-old girl with a history of epilepsy starting at 6 weeks of life, which was involving bilateral independent focal seizures. At 3 months of age, she developed infantile spasms that on EEG did not have hips arrhythmia, and which was refractory to treatment. She continued to have clusters of seizures several times a day. Often these consisted of brief tonic seizures that would shorten throughout the cluster to essentially spasms as they would go forward. So that might last 10 to 15 seconds for the first one, and then a little bit shorter for the second one in the cluster, and then shorter and shorter until they were really just a second or two long, more consistent with spasms. She had global developmental delay, including severe hypotonia. She was able to sit, but required assistance, and she had decent head control. She was able to hold objects in her hand, but they had to be placed, and inconsistently would reach for objects. No verbal output in terms of words, but did have consonant-based babble and was highly emotive with friends and loved ones, and able to communicate some of her wants and needs and connection to others through that process. Constipation was a constant issue and required a strict bowel regimen to be maintained. She did not make eye contact fix or follow with examiners. And 4 to 5 nights per week, she would stay awake in her room all night. And the parents described this as her having an all-night party. She was often sleepy during the day, but not always. And she was content again at night, but awake. And she has a normal MRI. Next slide, please. So based on that whole presentation, what I've given you so far, what would you describe as the most likely etiology for seizures? And we're using the ILAE structures here. So structural, genetic, infectious, immune, or unknown. All right, excellent. So a small vote for structural, infectious, immune, and unknown, but the majority pointing towards genetic as the most likely etiology. Excellent. And we can go to the next slide. So CW was diagnosed with CDKL5 deficiency disorder. So this certainly falls into a genetic etiology for developmental and epileptic encephalopathy. And while I would say that in this particular case, for those who are familiar with CDD, there are some features that kind of point more directly to CDD: early onset of epilepsy, infantile spasms without hypsarrhythmia, which tends to be more common in CDD than in other DEEs, some suggestion possibly of cerebral or cortical visual impairment, clustering of tonic seizures and spasms. Those kind of point towards CDD. But I think more importantly is that a constellation of early onset epilepsy, developmental delay, several other neurologic manifestations with a normal MRI is going to point very strongly towards genetic. You'll notice I took off metabolic. Metabolic is certainly a consideration as well. And I see genetic as metabolic as really being connected in many ways. Next slide, please. So on this particular visit at 6 years of age, the parents' primary concern is, as they put it, it'd be nice if seizures were a little bit better, but they're okay. So they're not necessarily driving for seizure changes at that moment, but they do make this point about sleep. CW doesn't sleep. While she is content and awake all night, she is often disruptive through the night to siblings and parents. This is not necessarily that she's upset. She might be laughing and babbling to herself, but sometimes is screaming also. She's also been seen by an ophthalmologist who says her eyes are fine, but the parents say she doesn't look at me. Next slide, please. So at this point, I'm curious what the audience would do next in terms of most appropriate management. Would you add a new seizure medication to try to get the seizures stopped? Would you kindly tell the family that these are problems that we see in CDD and that we're sorry, but there's nothing that can be done about them? Would you think about a treatment trial for something for sleep? Or would you send the patient back to her pediatrician and ask them to address their questions? All right, so we have 17% for adding a new seizure medication, 6% that this is just part of CDD, 60%, excellent, or would think about a treatment trial for sleep, a sleep medication, and then 15% would send them back to their pediatrician. Thank you very much. Let's move to the next slide. And what I'd say here is there's not necessarily quite as directly a right or wrong answer in this particular case for this question. But I appreciate that there was some spread and that a majority of people would consider a sleep medication. So to continue that case forward, after discussion with the family of CW symptoms, we felt that that was most consistent with sleep dysregulation that we often see in DEE. That's not sort of an official diagnosis, but that's how we think about it, that the brain has a difficulty in regulating sleep patterns. There were no red flags for obstructive sleep apnea or other behavioral explanations for poor sleep hygiene. So it really seemed like it was a neurologic manifestation of their disease. We started a low dose of trazodone before bed, and on follow-up, the parents were incredibly appreciative of that. There were still some nights, about once per week, where she'd be up at night and somewhat disruptive, but overall things were dramatically improved, down from 4 to 5 times per week. Parents were still concerned about eye contact. So I've added here just a couple of facts around CDKL5 deficiency disorder as a representation of DEEs more broadly. We often don't have great data about what this looks like across all DEEs, but I'll use this as some to give some flavor of what we see, that about half of patients have a meaningful amount of sleep dysregulation or dysfunction. It's often associated with significant decrease in quality of life, and we have data that supports that. And about 30% of patients that have CDD throughout the US centers where we're treating patients were noted to be on some sort of sleep aid. Medications are relatively safe, and I've listed a few here that tend to be our starting point, including trazodone, clonidine, gabapentin. There can be others as well that we think about using to support sleep. These are not necessarily sleep designed medications, but we take advantage of some of the side effects of these meds and their good safety profile overall to consider utilizing them to support better sleep hygiene. Next slide, please. So the next question, I've sort of alluded to CVI a few times, and I want to know what do you all think needs to be done in order to establish a diagnosis of CVI? Again, some people would refer to this as cerebral visual impairment. In the US, it's tended to be cortical visual impairment, but in either case, what do we need to do in order to establish a diagnosis? Send them back to the ophthalmologist for additional exam, perform a detailed neurologic exam focused on eye function like fixing, following, conjugate gaze, roving eye movements, OKN or optokinetic nystagmus. Would we think about performing visual evoked potentials in order to establish that diagnosis? Or are there some skeptics in the group who feel that she really doesn't have CVI and this is not relevant to this patient's case? All right, no skeptics in the group. A few would like to have the ophthalmologist engaged, and some would feel that there could be value to a visual evoked potential. But again, the majority, about 2/3, feel that a solid neurologic exam is what's necessary. Excellent. Let's move to the next slide. So I wanted to provide a little bit of background about CVI and CDKL5. Again, as an example for DEEs, we have a variety of DEE clinics and see patients, and I've diagnosed patients with CVI across a whole range of developmental and epileptic encephalopathies. Unfortunately, I think CVI tends to be somewhat underdiagnosed across the DEEs, and so we don't have clear data about how common it is. We do know in CDKL5 that we see it in about 70 to 90% of CDD patients, depending on the study you're looking at. And it's probably varied across DEEs, but it's something we should at least be looking for. And as the poll results showed, it really is a clinical diagnosis, and in my opinion, should be able to be made by a neurologist. I always tell my trainees, you'll never diagnose CVI if you don't look for it. So we do have to think about it and be watching for it. As long as there's been a good neurologic or a good fundus exam, either by an ophthalmologist or by a neurologist who feels competent in a fundus exam, that should be adequate to say that there's not ocular disease. And if the signs and symptoms are there of poor vision, then that really establishes the diagnosis. And I think it's important to then have a context here. Why do we care about establishing a diagnosis of CVI, and what does that do? particularly in children who have poor developmental attainment and low function, it really influences how parents think about and engage with their child. I've had numerous parents who tell me that they don't think that their child relates to them because they don't have good eye contact. And I think reassuring them that the eye contact is a vision function issue, and to connect with their child through other aspects of their emotive relationship can be profound for families. This influences our approach to therapies and accommodation. Oftentimes, patients are presented visual stimuli to learn or develop or engage with, and if they can't see it, then they're not going to be set up for success in the first place. And then there may be other ways in which within the DEEs, there's some evidence that severity of CVI has some correlation to overall developmental attainments and severity, and may be useful as sort of a biomarker or predictor for severity of disease, which could be helpful as well, though more research is needed in that space. So I had provided CW with a diagnosis of CVI. We gave some anticipatory guidance around how this could be integrated into therapies and approaches in school for individuals with reduced vision, and allowed them to take that back to their community providers in school. Next slide. So I don't want to ignore seizures completely. I know I've been talking about all the other outcomes beyond seizures, but seizures obviously are an important component of treating any DEE. And so I thought I would share a little bit around sort of the approach here with DEEs, which may not always be the same as in other conditions. Epilepsy is often very hard to control in DEEs, though we're starting to understand more about the nuances of which DEEs may be able to achieve seizure freedom for periods of time, and which ones that really is quite unlikely. CDKL5 happens to be one where it is quite unlikely. Less than 10% of patients at any given time tend to be seizure-free, and only about half of those will sustain seizure freedom for longer periods, more than a year or so. We obviously want to make efforts to control seizures, and I always tell my families, even when we've had several medications fail them already, that it is worth continuing to try. However, we have to have some balanced approach, and I think of this as sort of a palliative even approach to epilepsy management, where we're balancing the negative side effects of medications, sedation, hypotonia, dysphasias, and we are trying to reduce the most severe impact of their epilepsy. If they're having large generalized tonic-clonic seizures with significant post-ictal states, we're trying to reduce the overall encephalopathy from frequent seizures, reduce hospitalizations, but it may not be realistic to actually stop all seizures without having too much of a detriment on quality of life. And so there's a bit of a balancing approach in which a real collaboration with the family is necessary in order to achieve that balance. Next slide. So summarizing some of the things I talked about just briefly, DEEs have numerous neurologic manifestations beyond the seizures. And while seizures are problematic, they're not always the most impactful neurologic manifestation at all visits throughout the course for that individual. And they may not be the thing that is most amenable to treatment. If we are able to reduce the sleep dysfunction or other aspects of their disease, that may actually have a bigger impact on quality of life than what we can achieve by throwing the next seizure medication at them. Sleep dysregulation is common. Cerebral visual impairment is common. It is, of course, important to treat seizures, but we want to do that within the larger context and balance approach to maximize overall quality of life in the DEEs. And I appreciate everyone's time and invitation today. Some references provided.
Thank you, Scott, for that nice illustration of the problems we see with a specific issue with regard to CDD and developmental and epileptic encephalopathies. One thing that's come up in the chat is somebody's asked what CVI means. It's cerebral visual impairment or cortical visual impairment, depending on but just so people are aware. But with the illustration that you showed, do you have we as neurologists are usually used to having multiple issues within the clinic, but I presume there is some degree of a multidisciplinary team approach to some of these problems because they can be quite complex.
Yeah, I think that's absolutely right. We're big on multidisciplinary care at our center and strive to provide that across a range of developmental and epileptic encephalopathies. I don't tend to handle GI issues, for example. I do think there are some boundaries on what we would handle as neurologists, but I've tried to highlight here some of the things that I think can be within our domain as neurologists, even if as epileptologists, they're not epilepsy and we don't always like to take care of these other neurologic manifestations. But ideally, across recognizing this audience has a wide range of care settings that we're discussing, but ideally some sort of team approach to being able to handle the variety of issues associated with DEEs is certainly ideal.
Thank you. And perhaps we'll return to that, to the Joe setting in the discussion point at the end. So next speaker is Sallie Baxendale, who is Professor of Neuropsychology at UCL in London and also consultant neuropsychologist at UCLH. And she's going to talk about some of the comorbidities and the outcomes beyond seizures from a surgical context. So thanks, Sallie.
Okay, thank you very much. And thank you, Helen, for inviting me to participate in this, and also everybody who has tuned in to listen to us. So I'm going to be talking about how to understand the cost and how to also pay that price of seizure freedom following epilepsy surgery. And I'm going to be focusing on an adult case for this particular presentation. So next slide, please. So whenever we work in an epilepsy setting, there's a lot of focus on seizures. We spend a lot of time characterizing those seizures, working out where they're coming from, what sort of seizures they are, and everything is really, really focused on seizures, particularly when we come to epilepsy surgery, because we're looking to see whether or not we can get rid of those seizures. But one of the problems with being so focused on seizures is that we tend to forget about all of the things that come with seizures. And we've heard a little bit about that today from the previous presentation. So seizures are just one manifestation that something's gone wrong with your brain. And all sorts of other things can arise from that. So there may be cognitive problems, there may be behavioural difficulties. And again, we've had a really nice presentation from Joe this morning about how those behavioural difficulties can really impact on people's lives. Also things like anxiety and depression. There's a bidirectional relationship between these things and having epilepsy. So next slide. One of the difficulties with some of these things that are classified as comorbidities is that actually these are an everyday feature of living with a diagnosis of epilepsy. So somebody may have a seizure once a month, once every 6 months, but they live with these so-called comorbidities every single day. So it's part of the condition. Next slide, please. And one of the real problems is when we are really focused on seizures, a lot of the treatments that we give to people to control seizures actually make some of these comorbidities worse. So some of the anti-seizure medications that we give to people can have quite significant impacts on their cognitive function, their attention, their processing speed, sometimes their language abilities as well, depending on the medication. And also even surgery, even when somebody's a very good surgical candidate, cutting out a bit of somebody's brain does not come cost-free when it comes to cognitive function. So all sorts of functions may be routed through that bit of the brain that we are removing, and somebody may experience memory difficulties, all sorts of difficulties afterwards. Fortunately, we are getting better at working out what will happen to somebody's cognitive function if we are going to offer them surgery, and also helping them to cope with that. And I'm really going to be talking about a case that illustrates this. So if we can go on to the next slide. Before we do that, I just want to give you a little bit of a quiz. So I just want you to think about what proportion of people with medically intractable epilepsy, so these are people who their seizures are not controlled by medication, what proportion of those people do you think demonstrate clinically significant memory impairment on formal tests? And by clinically significant, I mean they perform below the second percentile. So really quite significant difficulties on memory tests. Just have a look at that. Do you think it's under 25%, 26 to 50%, 50 to 75%, or over 75% of people who have really significant memory difficulties, people with epilepsy? I'll just let you have a think about that. Okay, that's interesting. So that's a sort of reasonably kind of even split across those. So about 10% if you think under 25%, some of you, 37% think it's between 26 and 50%. And that probably reflects the type of patients that you work with, or also if you have epilepsy, whether or not you have you experience those difficulties. So the actual answer, if we go on to the next slide, is between 26 and 50%. So it's actually 30% of people. Can we go on to the next slide? So I'm going to talk to you about a case study, a lady called Rosalind, who was referred to us for epilepsy surgery. And if we go on to the next slide, I'm just going to talk a little bit about her clinical history. So she was a 34-year-old woman. She was university educated. And in retrospect, her seizures probably started in her mid to late teens. She reported very strong feelings of déjà vu and also episodes of where she felt she was zoning out at school, and particularly in sixth form, these got worse. But she was actually diagnosed at the age of 22 when she experienced her first generalized tonic-clonic seizure. She was commenced on medication and that controlled her generalized seizures. But she continued to experience focal seizures with no loss of awareness every 2 weeks. And these would progress to focal seizures with a loss of awareness every 3 to 4 months. So she was still having those really strong feelings of déjà vu and those periods where she would describe herself as zoning out, but which were focal seizures with loss of awareness. She coped okay with this. She continued on her medication, and at the age of 32, she became pregnant and gave birth to her daughter. Following that, her seizure control was really quite poor, and her focal seizures with loss of awareness increased in frequency. And she was working full-time as a lawyer in the City of London at this time, and was also trying to cope with being a mother of a 2-year-old daughter. And that's the time when she came to us for a surgical opinion. Next slide, please. So these are just a summary of the investigations. She came in for video telemetry and we managed to capture one seizure. And the ictal EEG onset indicated a left temporal lobe onset. And the semiology was consistent with a left temporal lobe onset as well. So this looked like a left temporal lobe epilepsy. Unfortunately, she was MRI negative. There was a slight asymmetry of the hippocampi. So the left was smaller than the right, but the volume ratio was about 90%. So it was just on the borderline, not quite enough to be clinically significant. fMRI indicated that she was left language hemisphere dominant. And in terms of her neuropsychiatry, there was no neuropsychiatric history, and there were no concerns regarding her understanding of the concept of surgery or worries about the support that she would have available if she went ahead for surgery. Next slide, please. In terms of her neuropsychology, she had a high IQ, so she was functioning around about the 75th, 80th percentile in terms of her overall intellectual function. And that was very consistent with her educational and occupational history. She had a degree and she was working as a lawyer in London. Her working memory and her processing speed were relatively weak. They fell in the average range, but they were lower than we would expect given her overall level of intellect. She had good visual memory skills. Her verbal memory, again, was a relative weakness in her profile. It wasn't clinically impaired. She was by no means below the 2nd percentile, and her scores were in the lower half of the average range. But just relative to her other functions, that was a relative weakness in her profile. Her receptive language skills were very good. She did have mild word finding difficulties evident on naming tests, and she did report these as well subjectively. Her executive skills were exceptionally strong. She was a very highly organised woman, both in her everyday life and also at work. And in terms of her subjective reports of cognitive function, she reported word finding difficulties, particularly when she was tired. And when she was studying her cases in her work as a lawyer, she had to use active study techniques. So she would make notes as she was reading, and she would repeat things, and she would summarize things. And she was very reliant on that to get by in her work. But she was able to manage, and she was working on a full-time basis. New slide. So in the MDT discussion, we all contributed our findings to this, and it was fairly clear that she had a left temporal lobe epilepsy. There was consensus about that. The EEG was concordant. She was MRI negative, and she was offered a 60% chance of seizure freedom. But we did think that there was a high chance of postoperative decline in verbal memory function, and possibly language ability that is typically associated with an anterior dominant temporal lobe resection when somebody has function to lose. So if we go on to the next slide, I think this next one is one of the polls I'm going to ask you. So in your service, or from your perspective, is this patient's good memory function, is it a cognitive contraindication to surgery? So she shouldn't go for surgery because actually she's got function to lose, and she's going to certainly notice a memory decline after surgery. Is it a complication of surgery, something that's just a risk, just a complication of surgery? Is it an indication of the likely cognitive cost of the surgery? So this is the price she's going to pay for a chance of being seizure-free, or is it all of those things? So I'll just give you a little chance to think about that. Okay, that's interesting. Okay, so some of you, 3%, think it's a cognitive contraindication to surgery. And possibly it is. So we'll go on to have a chat about that. It could be. A cognitive complication of surgery, 12% of you think that. It's not a complication of surgery because a complication is something going wrong. And this isn't something going wrong because we can predict it beforehand. We think it's highly likely that this is going to happen. An indication of the likely cognitive cost of surgery, yes, that's definitely that. So if we go on to the next slide, just to look at those different things. So when we think about poor cognitive outcomes associated with epilepsy surgery, we can group them into these 3 categories. There's a contraindication, there's a complication, and there's a cost. So if we go on to the next slide. A contraindication is where there is an unacceptable risk of a loss of function associated with the surgery. And this is really an interaction between the magnitude of the calculated risk, so how likely is it that this is going to happen, and the extent and nature, how bad is it going to be? So for some patients, they won't be offered surgery because the chances of a catastrophic, devastating cognitive outcome are too high. So if we think somebody's going to become amnesic, we wouldn't offer them surgery. So that would be a contraindication, and that would be a decision of the clinical team. But for sometimes it's the decision of the patient because they're not prepared to lose what we think they may lose. So for those patients, a smaller risk of something not quite so disastrous may still be a contraindication because they're not prepared to go forward on the basis of understanding that may happen. So that's a contraindication. They don't go ahead. If we go to the next slide. A cognitive complication is an unexpected cognitive decline. So normally this is the result of a perioperative process. So there may be a bleed, there may be an infection, a postoperative infection. It's something that we do not expect to happen. Sometimes it can be something that's unanticipated from the pre-surgical evaluation. So somebody may not have, there are cases in the literature where somebody hasn't appreciated, or the team haven't appreciated, the contralateral pathology, and when they go back to look, actually you can see that it's there. Sometimes they haven't appreciated that somebody had bilaterally small hippocampal volumes, and when you go back and measure the volume of the contralateral hippocampus that's left in situ, you can see that it's too small. And sometimes these complications aren't always immediately apparent, so they don't always happen immediately after the surgery. They're not always apparent. When you have epilepsy surgery, it confers a lifelong vulnerability. So sometimes when seizures come back, and they may come back years later, and you may develop status epilepticus, or have a whole series of generalized seizures, you can burn out the remaining hippocampus, and then you can be left with an amnesia. So there are all sorts of things that can be classified as a complication. It's not something we're expecting. It's something we know that can happen, but it's not something that we're expecting to happen. Next slide, please. Really what we're interested in is the cognitive cost of epilepsy surgery. So these are anticipated. We know it's going to happen. We expect it to happen, because we know that's what happens if you cut out that particular part of the brain and you've got function to lose. So if we go on to the next slide. And this is really what people need to weigh up when they're thinking about epilepsy surgery. On the plus side, they're thinking about the chances of being seizure-free, or the chances of a significant improvement in their seizures, and they need to really think about what the doctors are telling them about that. But on the negative side, there's the risks associated with the surgery. So the surgeon will always talk about the chance of a neurological deficit, the chance of death, chance of worsening seizure control. All of those, the chances of that will be very, very small. And even the chances of a new psychiatric illness developing, chances of those things are small. We don't expect them to happen, but you need to be aware of them. But when it comes to a cognitive deficit, for some patients, the chances aren't small. They're actually more than 50%. We think it's likely to happen. So it's a cost of the surgery, not a risk of the surgery. And patients need accurate information in each one of these domains to really work out whether surgery is the right thing for them. So if we go on to the next slide. Fortunately, we can use all sorts of clinical information to work out somebody's risk of cognitive deficits, post-operative cognitive deficits in different domains. And we can plot what we think is going to happen to somebody's cognitive function after surgery. And then we can use a process called prehabilitation to use function before it is lost, to shore up and get all of the strategies and routines in place so that somebody can function optimally after the surgery. So if we go on to the next slide. Next slide. Because when it comes to deciding whether or not to have surgery, if we just press click, the thing that really tends to sway that decision-making is the expectation of being seizure-free. It's not just being seizure-free, it's what you think you can do once you're seizure-free and all the things that come along with that. So this is the thing that needs to be really focused on when we're looking at pre-surgical counselling. So if we go on to the next slide. So if we think back to Rosalind, she was offered a left temporal lobe resection and she underwent a left temporal lobe resection. And 12 months after the surgery, she was seizure-free. She had an outcome class 1, so no more seizures. She did have some mood instability. At 3 months, she became quite anxious and quite depressed, but she received some input for that. If we go on for the next slide. In terms of her neuropsychological outcome, her overall level of intellectual function was unchanged, so she retained her intellect, but she did have the expected deterioration in verbal memory, particularly in new learning, and her scores fell down to the 5th to 10th percentile. She had a significant increase in word finding difficulties, and she attempted to go back to work at about 8 weeks after surgery, which was too early. By 6 months, she was back to work, working 3 days a week, and was unable to actually increase her hours further. So at 1 year, she was still working 3 days a week. And the reasons for this were really multifactorial. So she had memory difficulties. She was struggling with her memory at work and was finding that quite hard. So had to take on a reduced caseload. She had mood disturbance as a result of these memory difficulties. It was a big blow to her self-concept. She thought of herself as a very competent person. She'd always coped really well with her epilepsy and being able to work full time and being a mother. And then following surgery, she was unable to do that. And there were also changing family demands in that her child was getting older and requiring all sorts of things in terms of childcare and nursery and moving on to school. If we go on to the next slide. So in terms of post-operative input, we're prepared, Rosalind, for the changes that we thought were going to happen following surgery, but that's not the end. You also need to have some input after surgery to help them adjust to the changes that she experienced. So we developed an acceptance and understanding, more neuropsychological testing and input to really work out what was due to the surgery, but also what was due to other factors in her life, because all of this was not due to the surgery. It was multifactorial. We did some work with her husband, really to help him understand why she was having the memory problems, and for him to also be part of her memory support, so that he could she could rely on his memory and not just hers. And we also got her some support for her low mood. Next slide. So really, just to summarise, using this case study, seizures are just one manifestation of the underlying brain disorder that predisposes someone to having seizures. So there's something wrong with the brain. We can see that's manifested with a seizure, but there's all sorts of other things that abnormality will be causing on a day-to-day basis. Many of the treatments that we offer to control seizures exacerbate these other symptoms of the underlying brain disorder. And when it comes to surgery and cognitive outcomes, we can think of these changes as contraindications. Sometimes we can't do surgery. Sometimes it's a complication. Something's gone wrong with the surgery. It's a risk that we know is associated with the event, but we don't expect it to happen. And sometimes it's a cost. We do expect it to happen. It's the price you pay for a chance of being seizure-free. We can mitigate these costs with appropriate therapeutic interventions before and after the surgery. And I'm going to stop there. Thank you.
Thank you, Sally. Illustrating that as normal epilepsy surgery isn't totally straightforward. Just while the other two come back online to enter this panel discussion, I'll just put one thing to you, Sally. You talked about prehabilitation, and that obviously may have resource implications, and some may even consider it a bit of a luxury. What are your views? I think as time goes on, more and more, the more we look for things, the more we find things, and the more we realise we could perhaps do something about it.
Yeah, I mean, personally, I don't think prehabilitation is a luxury. I think if somebody is going to undergo an elective treatment, it is incumbent upon us to make sure that they are making a completely informed decision about that. And in terms of neurological patients as a whole, we are very lucky with epilepsy surgery in that we get them prior to the insult. So if you're looking at brain injury or stroke or anything else, we get them afterwards and we have to work with them on the rehabilitation. With epilepsy surgery, we get them before the surgery, and we've got an idea of actually what they're going to lose and what they're going to keep. So that is an absolute gift to anyone who's doing neuropsychological rehabilitation. So I think it is incumbent upon us to use that to make sure that that patient is in the best possible position after surgery to maximise their chance of being seizure-free. So they're seizure-free and they can really use that. If they go through all of that, they're seizure-free, but actually the cognitive difficulties that they're experiencing really limit their quality of life, then it's not a good trade-off for them. So I think if we are going to offer this to somebody, it's part and parcel of the pre-operative evaluation. We put a lot of effort in making sure that we find the right bit of the brain to take out. We need to also be focusing on the other side of the equation, or what's it going to be like when we've taken that bit of the brain out. So it's two parts. With epilepsy surgery, can you find the focus? Is it okay to take it away? And it's that, is it okay to take it away that we need to focus on?
Thank you. So just to remind everybody as we move into the panel discussion, any questions, to put them in the question and answer panel. It's located at the bottom of the screen. And we've had quite a few questions already, but I'm going to start really by putting to each of the panelists really a question about the role of counselling. I think for Joe, the illustration about the neurosurgeon doing them on their own and really didn't come out with the best outcome. There's a comment in the chat about they don't involve the neurosurgeons. I think there's a bit of a, not sure what they think about that. Scott, there may be a difference, I suppose, if we're making diagnoses of the DEs, particularly the genetics of that earlier and earlier, and how we go about counselling of expectations in the longer term. And then Sallie, I suppose, the involvement of family members as well as even in adult practice. So perhaps I'll come to you, Joe, first.
I want to, thank you, Helen, because I think this is really important. So it's so frustrating when you see something that looks like a really great lesion and we can solve this, but actually it's not our individual decision. It's about teamwork, and it's about all members that are affected being engaged in the scenario. And I think you probably picked up, I was very frustrated for this particular patient that the intervention didn't happen, but actually the neurosurgeon was probably right, because if he wasn't confident enough to provide that service, then actually he shouldn't have been going in there. So potentially he could have actually made the situation worse if he was that insecure about the intervention. And that situation basically was the trigger point that we then sat down with them and completely re-looked at our whole epilepsy surgery approach and said, we're not doing this like this. This is how we do the care. And if you cannot work with us as a team, if we can counselling and come to a joint decision and a joint message as a group, then we shouldn't be doing it as a service. So it's that whole issue of where do you draw the line of what's actually okay for when you're delivering care, and you first must do no harm. So I love what Sallie's been saying about how you plan and you prepare and you think about the patient as a whole and you put the whole picture together. That even in a resource limited setting, it's so tempting to say, well, we could just pop in and do this. But actually, you've got to think about the big picture, because there are a lot more things that are going on and a lot more potential complications that are going to arise than just dealing with the seizures. So, I think these things are hectic, but they're really, really important to get right. You need to use them to lobby and make sure that we actually approach our patients actually in an appropriate manner.
Thank you. Scott.
Yeah, thanks for the question, Helen. I think this is something very near and dear to my heart. We did a study on this in CDKL5, and we looked at, through interviews with families, what their experience was like receiving the diagnosis. And we looked at it with a cohort of patients who were quite young, under 2 years of age, and we looked at those that were maybe older or even got the diagnosis in their teen years. And we found a stark difference in terms of what that experience was like. When diagnosing a patient at an older age after a prolonged diagnostic odyssey, there's often quite excitement about receiving an answer and finally understanding why is something happening to my child. Whereas if you have a 6-month-old and you're getting a diagnosis of something, you don't know what's going to happen for your child. You don't have a clear picture at that moment of where that child's future is and what your life is going to look like over the coming years. And receiving that diagnosis is a life-altering diagnosis. And this isn't always the way we approach it when we're talking with families. But I think it's really critical to recognize that there's a difference in terms of where a family is at the time that you're giving a highly impactful diagnosis, like a genetic diagnosis. There's certainly do's and don'ts of kind of how do you approach it and things like that. And these aren't unique to counseling for epilepsy or genetics. It's common, and actually much of the knowledge in this space started in the cancer literature around understanding where is the family by starting with questions, and then proceeding to give them small amounts of information initially. And that first life-changing diagnosis is often going to result in families not remembering anything else you talk about in that first meeting. And ideally, being able to bring them back in short follow-up and address additional questions and considerations. And I think the most important thing that came out for us was trying to convey a sense of community and support to families at the time that you're giving a diagnosis. Families feel isolated and alone, particularly in rare diseases. And you want to say, we're walking this journey with you. We're going to be here alongside you, rather than anything that's sort of, this is what it is, and dismissive in that process. So I think that's a critical component. And I would go one step further to say, regardless of when we're making a diagnosis or how we're conveying that information, this idea of counseling becomes a chronic thing throughout all phases of care that we're providing to these patients with DEEs. And it really is about having that collaborative approach with families. And if you're not listening and engaging with what their concerns are, then you can't build that collaboration and really support that family.
Thank you. Sallie.
I mean, I would echo that completely, but I think that's something that we quite often miss when somebody moves into the adult services. So there is always a focus on the family when they're children, but as soon as they move into the adult services, we kind of forget about the family. So we really do try to include as many family members as possible when they are doing the pre-surgical counselling, because when somebody comes for epilepsy surgery, particularly if they come as an adult, they're bringing in all sorts of expectations as to what they think will happen. Now, the only thing that is going to happen is that the seizures will go. That's the best scenario. We can get rid of the seizures. We cannot get rid of that life lived with epilepsy. And many of the problems that people cope with on a day-to-day basis is due to the life lived with epilepsy, and we can't erase that. So speaking to the person with epilepsy about that, and also speaking with their family members about that, I think really helps them understand what epilepsy surgery is about, how it can help, and where actually it's not going to help, but maybe other things can. So even for people where epilepsy surgery is not an appropriate intervention, they may go through all the pre-surgical intervention evaluations and surgery is not a possibility. There's still things we can do to help them adjust to living with epilepsy, in the same way that we use those techniques to help them adjust to living without seizures afterwards, because there's a lot of things that are attributed to the epilepsy that maybe we can do something about, particularly when it comes to anxiety and low mood, and including the family in that, and including partners and sometimes adult children in that can be really, really helpful. And I think it's something that in adult services, we don't spend enough time really making sure that those people are included. And actually, I would go wider. I think every adult epilepsy surgery program should have an OT involved. You know, I think they should be out there. They should be working with employers, getting people back to work. All of the brain injury models that are used in brain injury, we're not using them in epilepsy surgery, and we should be, I think. It should be a much more multidisciplinary approach after surgery. It's very multidisciplinary before, and then off you go. And that's not the way to go, not the way to maximise what these people have been through.
Thank you. I think that touches also on something else I was going to bring up, not least, you know, we have this variety of symptoms in these patients, and particularly I see this in children, but it probably happens in adults, maybe it's neuropsychiatric, cognitive, and that, you know, when you're trying to address them, there's a belief that perhaps it should be a different approach because they have epilepsy, as opposed to utilising some behavioural approaches or medication. And there's one specific question about use of melatonin, for example, Scott, that I'll come to you with the sleep disorder for comment. I just wonder whether I could come to you all to get your views. Perhaps start with you, Scott, if that's okay.
Yeah, absolutely. Melatonin is a very reasonable place to start with a DEE patient who has some sleep dysregulation. I would caveat that with the one challenge is melatonin tends to be helpful in initiating sleep, but it may not be as helpful in maintaining sleep through the night. And many of these patients who have just an overall inability or difficulty with regulating sleep, that may not be adequate. So in some cases, another medication is necessary to try to help, or a different option is better to help them maintain that sleep through the night. But I think it's fine. And I think to your point, Helen, we don't have to reinvent the wheel. There's lots of good sleep medications, and they're the same ones that are helpful at least from my perspective, in a pediatric population in which you would use those medications, whether you have epilepsy or some other cause of a neurologic sleep dysregulation. And I think that's true across a variety of areas. We see that within ADHD and epilepsy. We see that across the board. We don't have to come up with new alternatives in the vast majority of cases in which we're addressing comorbid conditions in epilepsy. I think you're muted, Helen.
Not helpful. I was wondering why I got a blank look. And just come to Joe, perhaps, and then Sallie, about utilising other, especially in your setting, Joe, utilising more behavioural measures, even where epilepsy is an issue.
I mean, so it's actually fascinating. It's the whole thing of ask the right question. So the families come in and you say, how are they? They say, they tell you about the fits. And unless you ask directly, they assume you're not interested in anything else. And in fact, we had a study we did recently. I saw somebody put a post up about using apps and wearable devices, which they're even coming in here. We did try them, but the kids were too scared to wear the watches in case they got mugged. And they broke most of the phone apps, but we gave it a go. What did come over was that all the families, when they were asked directly, says, no, he sleeps fine. And when we actually then looked at it, we realized nobody was getting any sleep in any of the families. And when we asked them, well, what was happening? They were all sleeping in the same room, obviously in the same bed. And so none of them were sleeping, and they thought that was their normal sleep pattern because that's what they'd always had. And that's what they thought was okay. And it hadn't actually occurred to them what a knock-on effect, because that was like their life. And that they could also raise it in the middle of an epilepsy clinic, that we were interested and we wanted to know and we wanted to explore what we could do. I'm not sure that we actually resolved many problems, but at least we could talk through some approaches to care with them. So I think you can never underestimate the damage that not sleeping has. And then for the neurobehavioral issues, the other problem we have is that when the kids come to clinic, they're not always brought by the direct caregiver. And again, if you don't ask the right question, you'll say, how is it? And they'll give you a vague answer about the seizures, and then you won't get a direct answer about what's happening to the behavior. And that's because they don't really know the patient, because they're the auntie. And so unless you actually ask the right question, you won't get your answers.
Thank you. Sallie, have you got any comment?
Yeah, so I think when it comes to kind of non-pharmacological interventions, something that really struck us in a recent study we did was looking at anxiety, at preoperative anxiety, and how that is related to post-operative satisfaction with outcome. So regardless of whether somebody's seizure-free or not after surgery, it's their satisfaction with the psychosocial outcome is predicted by preoperative anxiety, and that's something that we can do something about. Anxiety, there are lots of treatments for anxiety. Anxiety management is a very standard treatment, and it's something that we should be offering everybody. And if we can do that prior to surgery, then actually their satisfaction with the post-operative outcomes will be greater. So I think there's all sorts of things that we can do when we are looking, just widening that lens away from just seizures. And regardless of whether somebody goes for surgery or not, we can have some impact on their quality of life. So I think, yeah, always have that focus on. Somebody in the chat has said, you know, what can you do if you haven't got access to surgery? Well, there are things you can do, and something like that, anxiety management, and looking at sleep, as we've heard, and things like that can have an impact on somebody's life.
Thanks. There are several questions about whether there are specific protocols post-operatively, and I think we could look at this both adults and children, and specifically around also speed of anti-seizure medicine withdrawal, which I think is probably relevant because we know that actually long-term outcomes may be related to coming off medication, and it's something that may be really focused in the minds of particularly parents, and I'm a paediatric neurologist, so I'm probably a bit biased, but I'm sure it's in the minds of adults, perhaps less so. They're a bit scared of coming off anti-seizure medicines, perhaps, but maybe I'm being presumptive. So I just wonder about comments about protocols post-operatively from the three of you, really. Joe?
We do. So, I mean, we are super cautious because a lot of our patients come from all over the place in rural areas. So we generally ask the referring clinician not to touch the anti-seizure medications for 6 months. I do know that there are centres that are successfully able to wean from 3 months, and there's this discussion that if the seizures rebound, it was inevitable and you're just uncovering whether they happen. But we're so nervous about that happening in a remote setting that we tend to be very cautious. So we bring them back at 6 months, we re-counsel the family, we redo their neuropsychology, check for any other sort of comorbidities and other issues, and then at that point we give them a very clear, gentle tapering regime with and then bring them back later. So that's just the policy that we follow. But I know that it differs in different parts of the world.
Thank you. Sallie, what do the adult? Oh, Scott, do you want to go first? I've seen you just opened up.
Yeah, I was just going to add to that there is a lot of variability even within our own center in terms of how different epileptologists approach this. One thing that I think is a reasonable balanced approach is if a patient is going into the preoperative space on 4 or 5 anti-seizure medications, to be relatively aggressive in trying to reduce the number of anti-seizure medications somewhat more quickly, but not necessarily to get off all of them. And this is, again, that balancing of the negative side effects of being on lots of medications or higher doses with trying to not pull the rug out from under them, so to speak, with surgery. But overall, getting off of meds entirely, we tend to be a bit more conservative as well. And I'll turn that over to Sallie.
Thank you.
So I'm not a neurologist, so I don't prescribe, but I know that generally in our service, people will stay on the same medication for at least a year. And the problem with that is once you've been seizure-free for a year, you can then drive. So they're very reluctant to then come off those medications, reduce those medications, because one seizure will then put you back for another year off the road. So our adult patients tend to stay on the medication for quite a long time, and particularly if they're seizure-free, because they do not want to risk that one seizure coming back and losing all of the benefits that they've got from being seizure-free for a year or more.
Thank you. And I think it's borne out in studies to show that children are much more likely to come off medication than adults. And that's probably not a reflection of risk of seizure. It's probably a reflection of desire and fear, really, as to whether they want to come off it, whereas parents are usually wanting to be quite aggressive in trying to get them off. So as another topic discussion, there's been a few comments in the chat about the relative role of the epilepsy, the medication, and the underlying cause, and how do we assess that? It's actually an impossible question. But I think I will come to each of you as to how you might weigh that up and how you might explain it, because, you know, families are usually fixed on medication. Seizures may be, not so much necessarily the underlying cause, and which may in fact have quite a lot to do with neurodevelopmental and cognitive outcomes. So just your views on each of that. Perhaps I'll come to Scott first.
I was hoping you were going to start with Joe on the impossible question.
Easy question.
Well, I think that in my experience, again, it's really about taking that time to form that partnership with the families. Often we don't have a perfect answer on etiology. There is a question about, you know, also what's the difference between structural and genetic etiologies. And I would remind people that with the ILAE schema, you can actually have both, right? So tuberous sclerosis is an often pointed to example where it is both a genetic and a structural etiology. And the more we dig into structural etiologies, including focal cortical dysplasias, we realize that there actually is a genetic underpinning for many of those. But I think that the discussion with families is around what do we know and being honest about that, and what do we not know? And we tend to not always be as comfortable being honest about that with families, but I think it's actually critical, and it builds trust with families. And you then reevaluate as you move forward, whether that's continuing to look for what you presume to be a genetic etiology, whether it's continuing to look for the structural source of focal epilepsy that may not be readily apparent. It's engaging around how do you think about that, and why does that influence how you think about the patient as a whole? Really, the etiology helps us to drive our framework for considering not just the seizures, but what are comorbidities I would potentially expect, should be, as Joe said, asking the questions about, because if you don't ask, they won't tell you. And I think my approach is to be very open and honest with families about what we know, what we don't know, and what I'm thinking and looking for as I consider it. And I find that to be, while somewhat time consuming, overall more efficient with families, because it invites that open dialogue, which we can then, in a trusting fashion, in the long run, have easier communication to address their needs more efficiently.
Yeah, thank you. Jo, do you want to add to that?
Yeah, no, to completely agree. I mean, just to chuck into the mix a compounding factor that we have a lot of phenobarbital still used. Not a great agent to neurobehavioral problems. So yeah, that the conversation about complications with anti-seizure medications is really, really important to have.
Thank you. Sallie, have you got any comments from a...
Yeah, so when it comes to the adults, I mean, we tend to use a kind of building block approach. So it's, you know, the underlying epilepsy, the abnormality that's causing the seizures is also causing some cognitive problems. So that's the kind of starting thing. And then it will be exacerbated by medications. And adults can be quite articulate about, look, when I started taking this happened. So they know what the impacts are. And then the seizures themselves, it's always just getting that balance between the more medication you take, the less likely you are to have seizures, but the more seizures you have, the more kind of cognitive problems you may have. So getting that balance is quite difficult. But we do talk to patients about those three factors, because they are all important, and it's not an either or. It's you're filling up a beaker, and it's just getting more and more full with all of these factors that go in there. So we can reduce some of them, but there's always going to be that underlying kind of cause there. So that's part of the prehab program actually is acceptance that this is part of the condition. It's not something different. It's different. It's not separate. It is all part of the same condition. Yeah.
Thank you. And I think we haven't answered all the questions. We've answered a considerable number of questions, and thank you to our panelists for the fantastic presentations and discussion. We've had in excess of 200 participating today. This it has been recorded and will be available from tomorrow for those who either wish to rerun it or for others who have registered. From tomorrow, you will also get, all those who've registered will get the case from the Academy that is related to consolidate learning. And of course, the pre-reading was circulated in advance. We will, at the end, there will be a QR code, which we will link to the survey with regard to your thoughts. And there's a few questions about evaluation of the webinar, and that will help us to structure our webinars as we go forward. We do have further e-fora planned for this year. Our next will be on the 28th of June on emergency seizure plans across the ages. We had one last year about rescue medication, but this will be more in depth about the relevance and the different types of seizure plan or emergency seizure plan that may need to be considered across the age groups. And there will be other e-fora later in the year on transition of care and also in older people, epilepsy in older people. So with that, I'd like to thank you all for participating, thank our panelists again for participating today, and wish you a successful day, afternoon, evening, night, wherever you are in the world for the rest of the day. Thank you very much.